paper on Monday is a paper about the use of targeted agents in the treatment of advanced non-small cell lung cancer. And we already made quite a history in that type of treatment. But the interesting about the new agent that we will discuss on Monday, Zactima, is that it's a targeted agent, an oral formulation that is targeting two pathways in one single drug. Because probably for more effective cancer treatment, what we need is not only inhibition of one single pathways, but perhaps of two or perhaps even more. So it's a progress. And the more targets that we can inhibit, the more successful the strategy will be. And Zactima is inhibiting two major pathways of lung cancer development. It's the pathway of the epidermal growth factor receptor, which is proven to be very important. And it's the pathway of angiogenesis, vascular endothelial growth factor receptor, which is also very important. And this treatment is taken together in one single oral formulation in Zactima. And so the study is going to tell about the results. This Zactima has been in phase 2 trials, but already is in several phase 3 trials now, where the results are reported. The results of three phase 3 trials are reported here at this meeting in Berlin. What I will report is one of the studies where Zactima is combined with standard chemotherapy in relapse treatment for non-small cell lung cancer. And what we saw there across the trials is that there is certainly an additional activity of the drug when it's added to chemotherapy. And this is for the first time actually in second-line treatment that you see that there is enhanced activity. Enhanced activity means there is more response, the disease is better controlled. In one trial there is a significant prolongation of time to progression. And perhaps most important of all in this type of patients, because they're not in a curative setting, there was a dedicated program of questionnaires asking for symptoms and quality of life. And the combination treatment with Zactima clearly improved time to symptom deterioration, improved aspects of quality of life, and that's quite relevant for these patients. Well, the outcome for the doctor in the clinic, of course, will be first, it's a good package of phase 3 clinical trials, so they need to go for registration first now. The impact may be that in general, for relapse treatment of non-small cell lung cancer, until now, it's clear that single agent therapy is what you have to do. So this is important because for the first time, it's giving us the signal that you can reach more efficacy, more patient benefits when you give combination therapy of standard chemotherapy and you add an oral agent. And above all, the combination treatment was reasonably well tolerated. So you make a small step forward. It's always a small step in non-small cell lung cancer. But you make a small step forward for a better strategy in relapse treatment. That symposium is on stage 3, non-small cell lung cancer, meaning locally advanced. So these patients are not in an early stage where they are often operated and often can be cured. They're not in an advanced stage where they cannot be cured. They're in between because of locally advanced disease. And it's a very actual topic because we know you have to treat these patients with combination therapies, and you can cure a proportion of these patients. It's clearly lower than in early stage disease. And one of the aspects is which treatment you have to combine. Has it to be surgery with chemotherapy? Has it to be radiotherapy with chemotherapy? Or has it to be all three together? And there is a lot of controversy on this because in some randomized control trials, you have the impression that it doesn't really matter, that it's the same with all strategies. But actually my conclusion will be that just like as we are in patients with stage 4 with advanced disease, we're talking about customized cancer care, meaning trying to get different drugs for different patients. There as well, we need to go to customized cancer care because for some patients, depending on how the disease is located and the number of lymph nodes and all kind of technical things, for some patients, clearly the best strategy is a combination of induction plus surgery. And for some patients, the best strategy clearly is a combination of chemotherapy and radiotherapy. And there are, of course, patients in between, and that's where we discuss about. But there as well, in stage 3, my main message will be in a time of customized cancer treatment. There's no recommendation, because that's the title of the symposium. Can we make a general recommendation for everyone? The answer is clearly no. We need to customize there as well. For some patients, surgery will be important. For other patients, surgery will not be important. And this is what the discussion will be about. MAGE-A3 is a protein located on the outer cell surface, so it's an antigen on the cell membrane. It was originally discovered in melanoma patients, that's where the names come from, of melanoma-associated antigen. But it is present in about 1/3 of patients with non-small cell lung cancer. So there is a strategy to give a certain immunotherapy against that protein. And the place where we develop that strategy is the patients with early stage non-small cell lung cancer who have had a complete resection of their tumor. And fortunately, many of these patients are cured. Some of them relapse. If they relapse, it necessarily means that there are remaining tumor cells after surgery. And so immunotherapy is a strategy, I think, that is well made to eliminate these remaining tumor cells. We do the same with adjuvant chemotherapy, and adjuvant chemotherapy has been proven to be efficient. But adjuvant chemotherapy has quite some side effects after lung surgery. It's not so very well tolerated. So the idea was, if you go for an immunotherapy against the protein in the patients who express it, 1/3 of the patients, you can eliminate remaining cancer cells and you can improve the time to relapse, or perhaps even the number of relapses, so increasing the cure rate. And this is what we do within the phase 2 randomized study that was reported some years ago at the ESCCO meeting. And there was a clear signal that could be the case. Could be the case because it's a phase 2 randomized study. But the signal was strong enough because the reduction in the risk of relapse was at least as high as with chemotherapy. And of course, it's immunotherapy, it's vaccination. So it's very well tolerated. There are actually nearly just minor side effects like with any vaccination, some local reactions, some fever, slight fever. But otherwise, for an anti-cancer treatment, it's nearly free of side effects. And so we saw a signal of efficacy with the treatment, which is really devoid of severe side effects. And this was very exciting to put it forward in what is now an ongoing phase 3 trial, which is of course a global trial because we aim to treat 2,200 patients, which means that we need, because the protein is expressed in 1/3 of the patients, so this means we need to screen at least 7,000 surgical samples, and probably you always lose some patients along the road. So we estimate that we will need to screen 10,000 surgical samples to include the number of patients to do the trial. Unfortunately, I mean, this is a huge effort, never unprecedented in patients with resected non-small cell lung cancer, but it's running well because the screening, the last update was at the World Conference on Lung Cancer, the last time that we discussed the data internally, and it's 3,000 patients already in, so it's running.